Good morning. Hello. Welcome to this session. My name is Jamal. I'm one of the foundation doctors currently based at the Royal Liverpool University Hospital. And today's session is going to be based and centered around perioperative care and post-op complications. Now, this session is quite thorough, it's comprehensive. Since it's going to be recorded, what we are going to focus on in this session is going to be all the high yield content and information, which is very relevant to anyone studying for end of year exams. And if you want a bit more information, please feel free to read through the slides and read the information on the slides, but I'm going to be focusing on the stuff which I found quite useful and quite important for the final exams. So let's begin and go through what we'll be covering today. So initially, we will start off by covering perioperative care and things that you need to keep in mind prior to going into surgery and into operations. Then we're going to look at general complications, those that are going to be applicable to any and all types of operations, followed by some specialty-specific complications. And lastly, we're going to go to other complications, things that are a bit more generic, a bit more general, and might not present with, or might not be relevant to certain conditions or certain diseases that are relevant later on. All right. So starting off with ASA grading. Now, ASA grading is very important because it determines operative risks and post-operative complications. And as you can see from this chart, it ranges from 1 to 6. And a very common question on the exam would be that they're going to give you a patient, they're going to describe some details, and then they're going to ask you to give them an ASA grade. So things you want to keep in mind is ASA 1, they're normal, they're healthy. ASA 2 is someone with mild systemic disease, usually doesn't really affect their life. So that's someone who might have some asthma, might have some heart problems, hypertension, that's usually well controlled. They might not take any tablets, maybe some diet-controlled type 2 diabetes, and they might just be happy with where they are, no issues at all, and they don't really pose much of a risk towards operation. ASA type 3 is someone with a more severe systemic disease. This is where we approach onto the topic of multiple comorbidities, heart failure, hypertension. This is something that would be manageable with some medication. Overall, it is quite stable. These patients do experience some substantial limitations from the disease. They might struggle to walk up or down stairs, they might have a pacemaker, but otherwise they're able to cope with an operation and shouldn't have any major issues. ASA type 4 is are the patients that are more severe. There are going to be the types of patients that have had recent cardiovascular events. They're going to be the patients with any ongoing ischemia. They're going to be the type of ones that are currently unwell and might have sepsis, might have the DIC, or might have some really severe renal failure. And lastly, ASA 5 are patients who are bound to die and they need the operation to basically survive. And lastly, ASA 6 are those who are brain dead and you are basically harvesting their organs. So most important thing with this is to be aware of the different types and the main differences. It's quite difficult to differentiate between ASA 3 and ASA 4, but the main thing is you want to look at is how severe is their condition. Is it life-threatening or does it just impact their day-to-day life? All right, next is this BMJ article. I found this very useful early on to just look at the different approaches towards preoperative surgery. Things you want to look at as a type of surgery in terms of what's required, and then you want to look at what kind of things you want to prepare. In most cases, anyone who's coming in for any surgery, usually they have a perioperative assessment with an anaesthetist, they have the regular bloods done, they have an ECG just to make sure that one, you have baseline, and two, that they're not in any arrhythmias. And so bloods, ECGs, and if they do have any issues in terms of they have severe lung disease, they have severe heart disease, that's where we might consider further investigation, including some pulmonary function tests and some echoes. But otherwise, this is the basis. Okay. So looking at the slide, this is quite a high yield slide in the sense where a lot of these conditions tend to come up on exams. The first one is malignant hyperthermia. It's a autosomal dominant genetic mutation that basically causes reaction to many other anesthetic agents and dexamethasone. These patients tend to present with high rest rates, tachycardia, and the temperature, and it's associated with muscle rigidity. And this happens due to muscle breakdown within the body due to rhabdomyolysis. And as these muscle fibers are breaking down and muscle proteins are breaking down, this ends up causing a metabolic acidosis picture. In this case, the best way to treat it is because they're quite warm, they're hyperthermic, you want to cool them down, and you want to give them some dampening to reverse the action of the anesthetic. In this case, the main takeaway message with malignant hyperthermia is that it tends to present early on, and as these patients are being induced right at the beginning of the procedure itself. And this is important because when you compare this to succinylcholia apnea, the next condition, it tends to present at the later stage at the end of the operation. And that's just because these patients tend to have an enzyme abnormality, primarily with a plasmacholinesterase, that causes a reduced breakdown of these anesthetic agents and causes prolonged paralysis. So these patients at the end of the operation are going to make very little effort to breathe, and you're going to have a high heart rate, high BP, and the best way to treat this is just because the anesthetic is taking a long time to wear off, you want to make sure to keep them ventilated, you want to make sure to give them enough time just so that all those enzymes eventually end up kicking in and breaking down the anesthetic. So main differentiation is malignant hyperthermia early on in the operation, succinylcholia apnea later on, and at the end of the operation. And both present quite similar in terms of higher heart rate, higher rest rate. One, malignant hyperthermia, because it's breaking down the muscles, causes stiffness. Succinylcholia, very limited effort in breathing. And lastly, reflux. Reflux is just important because if you're trying to intubate someone, you want to make sure that the airway is protected, especially in cases where you might need a rapid sequence induction, and you might put in an endotracheal airway. You want to make sure that all the contents stay there and they don't get reflux. So in this case, you want to go for an endotracheal airway with a cuff to prevent any aspiration and flow into the stomach, into the trachea, and you want to avoid using any supralaryngeal or supraglottic airways. Okay. Next on, we want to look at eating and operating. So the main rule is 8 hours for any foods, for fatty foods, and 6 hours for any food and milk. And that's just because it takes enough time for them to go through the stomach, get cleared out, and emptied as well. Next, we want to look at 4 hours for breast milk. That's not quite relevant in most cases, but you want to keep in mind. And lastly, 2 hours for clear fluids. So the main cutoff we use in theater or in hospital is 6 hours for food, 2 hours for clear fluids. And you want to be aware of the elective list, and that's just because these patients come from home and they go straight into the operating theater. They're usually day cases, and in many of these cases, these patients just don't come prepared, and this is where you might run into that issue. So pre-op medications, this is very important. It's quite high yield, and this is probably the most important slide that you want to take in terms of what medications to stop. So you have oral contraceptives you want to stop 4 weeks prior, and you want to restart it 2 weeks after. That's just because there's an increased risk of clotting. Clopidogrel and warfarin. Clopy 7 days prior, warfarin 5 days prior, and that's just because they increase your, Clopy is 7 days prior, and very similar thing with aspirin, just because it increases your bleeding risk within surgery. You have warfarin, which is 5 days prior, and you might consider bridging as well with low molecular weight heparin, and then later on you can continue with that bridging, and eventually you can continue and restart them on that warfarin. Next, you have the DOACs, very similar thing, just because the DOACs work by inhibiting 10A, and what happens is they tend to last for 12 to 24 hours, so it's very easy to just omit them the day before the surgery, have the operation, and then start them the next day. They tend to work really, really well. Low molecular weight heparin as well, since they work on the same pathway as the DOACs and on the factor 10, what you want to do is you want to inhibit them 24 hours prior, and then you want to restart them 1 day after. In some cases as well, you might restart them on the same day, and you might go for a smaller dose. Lastly, ACE inhibitors, 24 hours prior as well, and that's just because they might alter some of your kidney function and might cause issues intraoperatively when there's higher stress, and some patients might run dry or might bleed a bit more than usual. And very similar thing with potassium sparing diuretics, just because they might affect the kidneys going through. So this is very much the most important slide. Try to remember these dates because they tend to be very high yield, and all the times they're going to ask you, this patient hasn't omitted, what do they do? And if it's something that's high risk, in most cases you do want to delay the operation unless it's a very important operation. All right, so with diabetes and surgery, things you want to keep in mind are how well controlled their sugars are and the type of operation they're having. So in most cases, you want to try to keep these patients early on the list as you want to minimize the amount of time they spend fasting, and that's just going to make your life so much easier when it comes to controlling their sugars later on and throughout the procedure. If it's minor operation where they're just going to have some local anesthetic, in most cases you can give them the insulin before or the day before the surgery, but on the day in the morning you can omit their insulin, have the operation, and then continue as usual. If it's a much more larger procedure or they're quite difficult to control their sugars, you want to consider switching to a VRI, which is a variable rate insulin infusion, and it just gives you a tighter control. So what you want to do is with a VRI, the concept is you keep these patients on their long-acting insulin, and what that does is it provides that basal insulin rate in the background, and then you're going to give them an infusion of insulin, small amounts, and adjust that according to their sugar levels hour by hour. So if they're running a bit higher than usual, you give them a bit more insulin. If they're running lower, you reduce the insulin, and it's much, much easier to control. And in most cases, just because insulin causes a shift of potassium into the cells and causes a shift of sugar into the cells, you run it with a potassium and a glucose infusion on the side. And while they're on it, you stop any other medication, any other oral tablets that are on it, just because it might interfere and make it much more difficult to control their sugar levels. Next is metformin. So metformin for people in hospital should be omitted, especially in an acute setting. And that's just because metformin interferes with the liver. It can cause lactic acidosis. And in a picture for patients, with these patients, if there's a high lactate, there's always a chance that this lactate might go through the liver through something known as the Cori cycle and cause glucose production, and that can just make controlling their sugars much more difficult, and as well can run the risk of messing around with their kidneys. So you'd only restart it when they're stable, when they're fit, and when they're closer to discharge. And lastly, you have the sulfonylureas, like glycosides, and you just omit those on the day of the surgery. There's a really good link in the bottom. I don't think it's quite relevant for your exams, but if you're curious, you want to have a look, go ahead. It's a bit more detailed information on how to control diabetic medication and when it comes to patients and their surgeries. Next, you have anticoagulation. Now, this is a really big topic, and it's quite difficult considering the type of the operation, how likely they are to bleed, and what the anticoagulation was initially started for. So looking at what anticoagulation involves, you have things such as low molecular weight heparin, enoxaparin, dalteparin, Clexane, which is the more brand name. You have unfractioned heparin, you have DOACs, which stands for direct oral anticoagulants, and you have warfarin. Antiplatelets are other things you want to consider, such as clopidogrel and aspirin, and each work differently. One stops platelet aggregation, the other one stops clot formation. And that's important because when you want to look at the indication why they started, most cases antiplatelets are due to vessel disease, while anticoagulants are due to prothrombotic diseases such as AFs or mechanical valves. Now, if someone's going for any spinal anesthetic, both anticoagulants and antiplatelets are contraindicated, and that's just because you always run the risk of them having a hematoma, a spinal hematoma that causes spinal compression and could significantly impair their function and eventually cause some non-reversible damage. In most cases, that's why you omit them pre-op. Clopi tends to be 2 days, aspirin tends to be 5 days, but it depends on the trust and it depends on the anaesthetist and the type of the procedure. DOACs, as we said earlier, just because they work on the 10A pathway, they tend to last for only 24 to 48 hours. So you omit them the day before, and they usually start them the night of or the day after. And they're quite easy to adjust, and you don't usually bridge them. However, patients on warfarin are much more difficult to work with, just because the fact that they're on warfarin, it tends to mean that they're usually monitored day by day. Warfarin takes about 72 hours to adjust its dosage and to take full effect, so there's always that lag period. And these are patients that you want to keep in mind, what are their targets. So if someone's coming in, they're on warfarin and the target's 2 to 3, you can think they're AF, and they're quite usually low risk of thrombus. But if their target is 3 to 4, they have a mechanical heart valve, that's a more serious condition. So what you want to do with these patients is you want to slowly set them down off the warfarin, and you want to start them on a low molecular weight heparin to cover and bridge in the meantime. And in most cases, what you can do is you can monitor the effect of the warfarin, and you want to aim for an INR of less than 1.5 for an operation. Sometimes people might be happy with an INR less than 2, but it depends on the surgeon as well. And in most cases, if someone if you need to have an operation but their INR is quite high, you can give a reversal agent, vitamin K, also known as IV phytomenadone. And if it's a more severe procedure, it's more urgent. Sometimes you might go for Octaplex, but to do that, you need to call hematology, and they tend to prescribe it. Timeline. So this is where we're shifting. So we've just finished our preoperative care segment, and we're going to look at the post-operative care issues and complications. So when you want to consider them, you want to look at the timeline in terms of when they're happening. If something's happening within the first 24 hours, it's different to something that happens between the first day to the first month, and lastly, it's things that happen long term. Things that we're going to focus on and that tend to come in exams are the first two boxes. So initially, in the operation, what you want to think of is damage or trauma to the structures. If it's structures of what you dealt with in the operation, or structures around what you worked with. So if you're messing around with the trachea or with the lungs, you might cause some orphan trauma. If you're messing around with the abdomen, you might nick it, you might nick an artery. You want to keep in mind that there's always things that you can cause damage to. And early on, there's three types of hemorrhage. There's primary reactive. Primary is bleeding that happens within the operating theater. Reactive happens as soon as you bring up the blood pressure, and we'll get to that later. 1 day to 1 month are things that tend to come up quite frequently in the exams as well, and we're going to go through them, and we'll get to that later on. All right, so when we look at hemorrhage, things you want to keep in mind are the different types. The first one, and we kind of touched up on this, is primary hemorrhage. It's what happens throughout the procedure, and it's usually just because you cut a blood vessel, it's bleeding, and usually it's easy to solve within the operating theater. Next, you have reactive bleeding, and this is what tends to happen at the end of the operating theater, end of the surgery. Throughout the procedure, patients tend to run at a lower blood pressure just because of the anesthetic agent and because they're lying flat. At the end, when you bring them up and you're slowly restoring the blood pressure, some of the vessels that you might have injured or damaged throughout or within the operating theater or within the operation might not fully appear till later on when there's a higher blood pressure, and that's when you might notice them. And lastly, you have the secondary bleeding, and this is where you have bleeding that happens 24 hours or after 24 hours post-operative, and this is what tends to come up on the exam for questions. So this is the high yield section. It's bleeding greater than 24 hours, tends to be secondary in nature, and in most cases it's due to infection, just because if there's anything that's breaking down the valves or breaking down any of the healing tissue, that's what's going to cause a lot of the bleeding. Now, when you want to come to manage it, the first thing you want to do is, if you can, apply pressure to it. Then you want to get a senior review. In the meantime, call them just so that they can come and assess the source. Is it something that needs theater, needs an operation? Is that something that you can control on the ward? It's a bit difficult. But the most important thing, this is the most important thing after you call your senior, is to activate the major hemorrhage protocol. And what it does is it helps facilitate getting blood for the patient, and it highlights to the lab that this is going to be someone who's going to need a lot of blood, and they're going to try to get it to you as soon as possible. And depending on the type of bleeding, you take them theater and you control it. Sometimes you're able to do it through IR. Next, going on to urinary retention, there's multiple different types. So not multiple different types, not different causes. The most important causes are drugs or pain. The main drugs we give are opiates and analgesia, and what that does is it reduces that sensation of going to the toilet and causes retention. Another common cause is anticholinergic, that causes blockage of the muscles that are required to expel the urine. Going on to pain, sympathetic activation basically causes us to contract our sphincter, and as such causes issues voiding and urine. There's also a psychological element where you're in a hospital environment, you're sitting in bed, it might not be the perfect setting to go to the toilet, and as such you might have urinary retention. Very rare, but can play an important role. Going on to the risk factors, you want to think old men, big prostates, and sometimes if it's something to deal with an area around the ureter, you might have issues as well. Going on to the management, sometimes just giving them some privacy, giving them some time might help, but in most cases, you want to give them some pain relief, and that tends to help void the urine, but a lot of the times that's not going to work, so you're going to pop a catheter in, give them a Satogent depending on the type of operation. If it's high risk, they have a graft, and you want to try to TWAC, and if that fails, bring them back later on for a TWAC clinic. Pulmonary atelectasis, very, very common. And these patients, what they do is they tend to present with symptoms of fever, symptoms of cough, difficulty breathing. And in most cases, you want to look at some of the risk factors. In most cases, if they're smoking or they have any issues with their lungs before coming in, big cause for them to develop atelectasis. You want to think of it as well in the sense of there's pulmonary, and if someone has an operation and then anesthetic is kicking in, then what happens is you have increased mucus production and you have low clearance. So a lot of it ends up causing plugging and collapse within the distal alveoli. And in most cases as well, that when combined with pain, people aren't able to take a full deep breath in and as such aren't able to get air to the lower parts of the lungs, then all that mucus ends up filling that lower region of the lungs and causing issues with respiration. And as we said, what you're going to do, first 48 hours, they're going to have a fever sometimes, they're going to have issues with breathing, and they're going to have dull bases. And what you're going to do is you're going to request a chest X-ray. In most cases, you can't see any visible consolidation. In this case, you can see some fibrous bands of atelectasis at the base, and management is just with intensive spirometry. You want to get them to take as deep a breath as they can so they can get rid of all that mucus plugging at the base of the lung. And in most cases, if pain is causing them limitations and they aren't able to take a deep breath in, you want to give them some pain relief. Going on to the next subject, wound infection. So wounds start to heal between day 5 and day 7. So any issues that tend to affect wound healing would happen within day 5 to day 7. Sometimes it can extend to day 10. In most cases, it's going to be the organisms that are already around the skin. In this case, it's going to be Staph aureus, very, very common, or coliforms. And on swabs, you're going to see coliforms +++. Very, very common. In most cases, the risk factor is the operation and exposure to these organisms. If it's a clean incision, you cut through the skin and only the skin, very low risk. If you cut through the skin and into the abdomen, that's a high risk. And eventually, if you cut through the abdomen, the bowel itself, it's high risk because you have exposure of bacteria from the outside and you have exposure of the bacteria from the actual bowel itself. And if someone comes in with a very dirty wound that's open, that's lacerated, that's exposed to soil, very high risk as well. And when it comes to looking at risk factors, the main thing preoperatively is what causes issues with wound healing. So diabetics, smokers, patients with very severe or very strong infections such as MRSA might make it difficult, and older people that might have a weaker physiological reserve, skin that's less elastic and less strong, less healthy, might cause issues. Intraoperatively as well, we said if it's a longer procedure, if it's a bigger incision, higher chance of it getting infected. And lastly, post-operatively, if there's any chance of contamination, it's likely going to cause any issues and cause wound infection. When it comes to management, you're going to treat with antibiotics to get rid of the bacteria, very simple. And if there's any drainage there, if there's any abscess there, then you want to drain it. And of course, you want to make sure the wound's clean and change the dressings quite frequently. Going on to dehiscence or dehiscence, however you want to say it. As we said, healing tends to happen between day 5 to 7. If there's any issues that happen within those days, if there's an infection, if there's a hematoma, if there's a seroma, something that causes issues with the healing, then you might end up with an open wound. And in most cases, sometimes you might have a lot of fluid that goes through, and just because it's a wet environment with fluid going through the wound, there's no clean edges that are able to get in contact and close up. And as per previously, anything that causes issues with wound healing, we talked about diabetes, we talked about smoking, would impact and put you at a higher risk of dehiscence. Management-wise, you want to think of this as an emergency, depending on how bad it is. So if it's just superficial, it's just the skin, you're fine. But if it's exposing the intra-abdominal contents, it's an emergency. You want to get gauze, cover it with sterile saline, apply some pressure, give them some antibiotics, and get these people into theater. We're able to close it up. And if it's exposing the abdominal cavity, do a full washout. And in most cases, you want to apply a back pressure, a vac dressing that's going to apply positive pressure on the wound and help get those wound edges together and get rid of any fluid that might impact the healing of the wound itself. Going on to specialty-specific complications. General surgery-wise, there's a lot of operations with cholecystectomy. If you're messing around with gallbladder, you're more likely to damage those organs. So if you're going to damage the CBD, you're going to cause issues. You're going to have some bile leaking, and that's probably the biggest issue at hand. With hernias, you want to think of it in two ways. Early on, you're more likely to have hematomas, seromas forming just because of the location and the nature of the area where it's very vascular. And later on, very common, if you've had a hernia form, then there's a high chance that you're going to have it form again, especially if you haven't used any mesh and it's just an abdominal wall closure. With appendicectomy, just because you're messing around, you might have infection. And lastly, with colonic surgery, you're messing around with the bowel, high chance of ileus, high chance of a leak if the wound ends up breaking down. And later on, just because you're messing around, there's inflammation, you're going to have fibrin deposits that eventually cause adhesion formation. But with any surgery, the two most common side effects are bleeding or infection. Going on to paralytic ileus, these patients, if any of you end up working a general surgery rotation, if you've managed to see any colorectal or general surgery patients, you're going to know it is quite common. And what happens is you go in, you touch the bowel, it goes crazy, it doesn't like it, it just becomes paralyzed. It becomes paralyzed. And other causes are giving anesthetics that cause the bowel to become really lazy, and sometimes electrolyte imbalances might affect the peristalsis and as such cause it to stop working. In most cases, these patients will present usually about day 5, day 7, sometimes earlier, with this tension. They usually haven't opened their bowels, they're usually vomiting, they're constipating, it presents with an obstruction. And when you come to auscultate for bowel sounds, you're going to see that there aren't any present. And this is different when compared to mechanical obstruction, where you're going to hear overactive bowel sounds. In this case, there's going to be none. Most cases, it's a clinical diagnosis just because they're post-op, they haven't opened their bowels, but you're going to go for a abdo x-ray, and that's just to confirm that there isn't any mechanical obstruction or any issues with the procedure itself. And what you're going to notice is you're going to have distended loops of both small bowel and large bowel with no focal points. And if there is any focal points available, if there's one point that's causing an obstruction, then that's more likely to be mechanical in nature. And as with the management of any obstruction, drip and suck, you want to put an NG tube in to relieve any proximal distension and help relieve all that pressure in the bowel. You want to give them some fluids because in this case they're going to be dehydrated. None of the contents they're eating or drinking is going to go through to the large bowel where they're able to absorb it. And if it's quite prolonged, usually if it's beyond a week, you want to consider CPN because they're going to be quite dehydrated, quite malnourished, and it's just going to impair healing and progression. All right, looking at other causes, with anorectal surgery, you're messing around with the bowel, it can cause narrowing, stenosis, and obstruction. In this case, you can have stenosis. As well, if you're messing around with the sphincter or the muscles, then you can have incontinence. With small bowel surgery, if you cut out a lot, you're going to have short gut syndrome, and there's not going to be enough time for the contents to go through and to get absorbed. And lastly, with the splenectomy, as it's an important organ that helps with fighting off bacteria, you're going to be at a higher risk for infection, particularly encapsulated organisms and salmonella. And with them, you're going to give them some long-term antibiotics. It depends per trust. In our trust, we give them long-term antibiotics, but some trusts, they give them for 2 years and they assess the risk as well. All right, other specialty specific, you want to think of vascular. Vascular surgery, you're either going in and you're relieving an obstruction, or you're going in and you're putting in a graft. So if you're messing around with the blood vessels, there's a high chance they're either going to clot off or they're going to bleed. And that's what you're going to see in this case. There's either going to be thrombosis and embolization, or you're going to see an anastomotic leak and they're going to bleed everywhere. And because you have a foreign body, if there's a graft, there's a higher risk of infection. And then when dealing with aorta, you remember that the aorta branches off to different parts of the body, branches off to the bowel, branches off to the kidneys. If you damage the structures, these structures that go off to other organs, then you're going to have issues. If you damage the renal arteries, you're going to have kidney injury. If you're going to damage the celiac, the SMA trunks that supply the bowel, you're going to have ischemic bowel, and so on and so forth. With breast, not many complications. Usually it's just localized infection. But of course, because it involves lymph node clearance, then that's going to impair the return and the flow of the lymph fluid back to the heart, and you're going to end up most commonly lymphedema in the long-term setting. Going on to urology, most common thing is sepsis. With urology and with the urinary tract, it's full of gram-negative bacilli that cause quite severe sepsis. So in most cases, that's what they tend to present with, just because one, you're exposed to that nature of the bacteria, and two, you're operating and you're exposing the body, you're giving them an opportunity to become quite systemic. Another one is urinoma, and we'll get to that later. With a prostatectomy, you want to think of damaging the structures. If you damage the nerves, you might have urinary incontinence, and as well, you might have erectile dysfunction. ENT, not much going on there, but what you want to think is with ENT surgery, they're working around the neck, so you want to be careful of the structures around the neck. So if you have a hematoma, that might cause pressure and obstruct the trachea itself. And because there's a lot of nerves going through, if you mess around, the most common nerve that tends to be injured is a recurrent laryngeal nerve. And in most cases, these patients present with hoarse voice. Sometimes it's transient, sometimes it's permanent, and in most cases, it's the right side. And that's just because it's closer to the operating site. It's more medial. And with the tracheostomy, things you want to keep in mind is you're messing with things closer to the trachea, they're more central. There's always a chance with any tube or with any pipe, whether it's bowel, whether it's airway, when you mess with it and you cause trauma and damage to it, it's going to tighten. But in this case as well, because you're causing an incision within the mediastinal cavity, there's always a risk for infection, mediastinitis, or with air filling in and causing surgical emphysema. This here is a CT, and what you can notice is there is kidney dilation, there's a collection around the kidney, and there's paracolic guttering down here in the bottom. And that's basically, in most cases, if you see paracolic guttering, it can mean that there's fluid in the abdomen. Sometimes it could be a collection if you're suspecting an anastomotic leak, or sometimes it could just be a long-term collection due to infection. In this case, just because we're looking at the kidney, there's a source of the leakage. In this case, this is a urinoma. All right, going on to orthopedics, what you want to think is if you're dealing with bone, you're trying to fix it. In most cases, it might not really bind really well, especially if it's not oriented correctly, and that can cause malunion of the fracture. As with anything, you can have infection, osteomyelitis, you can have issues with the blood supply, avascular necrosis, but the most important side effect of orthopedic surgery is compartment syndrome, and that's basically, it's a one-way, it causes the edema causes a one-way valve where there's blood flowing into the muscles, but the swelling causes obstruction of the venous return, and that basically creates a one-way valve where blood flows into the muscle, it doesn't flow out, and it causes compartment syndrome with increased pressures. And in most cases, you need a fasciotomy with 2 slits, medial and lateral, into all compartments. Hip replacements, very same thing. You can have infection, you have VTE, and in most cases, you're messing around with an area that is quite has a lot of nerves running through, and you can cause some damage to the nerves around there. Cardiothoracic, not something that tends to be high yield on the exam just because it's such a niche specialty, but as well, you're messing around with the mediastinum. You can either have infection, which presents as mediastinitis or empyema, or in certain cases, you can have air filling into the mediastinum, pneumothorax, or blood flowing into the mediastinum if you mess with any blood vessels, the hemothorax. And you can clearly see that on the right, where there's blood flowing into the mediastinum. You can tell it's blood just because it's white and it's liquid, and that shows up as white on the x-ray. All right, post-op pyrexia. This is where we're getting to some of our more general presentations. With post-op pyrexia, you always want to think of when they're happening. If it's early on, you want to think of things that we've talked about in terms of pulmonary atelectasis or infection, but you always want to think of things such as blood transfusion and drug reaction. If you're giving them something that's foreign, there's always a chance that they're going to react to it. And delayed-wise, you can always think of things such as pneumonia, anastomotic leak, wound infection, so on and so forth. And with any source of infection, when it presents, you want to treat with sepsis 6. Sepsis 6, sepsis 6, Buffalo. However you want to remember it, this is the main approach. And you want to always treat them with an A to E assessment to make sure that you don't miss anything at all. And in a surgical setting, when you come to examining these patients, you want to check for any possible source of infection. So other than looking at them from head to toe, you want to check their wounds, check their abdomen if they did an operation there. You want to check their legs to make sure that there aren't any PEs. and you want to check their urine and their stool. And investigation-wise, as we said, go through the full septic screen. Here are some of the other causes that might present with pyrexia, pneumonia, just because they're in a hospital. It could be a HAP, especially if it's greater than 48 hours, and in most cases you want to treat it through the HAP pathway with antibiotics and just analgesia. If it's a collection, these patients tend to present, as we said, within days 5 to 7 when the wound is healing. They're going to present with swinging fever just because there's an infection there, and occasionally some of that bacteria is going to go through the bloodstream, and every time it does, it's going to spike a temperature. They're going to have a picket fence fever, which basically means if you look at their chart, they're going to spike, then they're going to go back to normal, spike, go back to normal. That zigzag appearance is called a picket fence appearance. And just because there's infection within the abdominal cavity, it's going to localize a certain right or left side on the lower abdomen, and that's going to cause localized peritonitis. And if it's closer up to the diaphragm, it might be subphrenic and cause radiating pain to the shoulder. In most cases, there's so many areas where these fluid with this infection can end up collecting. You can see on here, I'm not going to go through them, but the most diagnostic approach is to do a CT and to find out where that fluid or where that collection is localized. And with anything, you want to give them antibiotics just because it's an effective source. And if it's large enough, you can put a drain in and drain it all out. If it's quite severe, sometimes you might get them in the theater and just give them a bladder wash, give them an abdominal washout. And with cellulitis, very superficial skin infection, and that's why I examine the wounds. And just because it's an effective source, you want to give them antibiotics. All right, dyspnoea hypoxia, very common. In most cases, as we said, atelectasis is common, pneumonia is common. You always want to think and make sure to rule out a PE or pneumothorax. In most cases, if it's a surgical patient, I wouldn't really act. I'd sit them up at 90 degrees, make sure they take deep breaths to fill in their lungs. And if that works, it's good. It tends to be related to pain, but otherwise, if it doesn't help, you want to go through, check an ABG, do a chest x-ray, and rule out all other causes. Reduce urine output, we talked about it. Usually it's urine retention is the most common cause, but things you want to keep in mind are pre-renal causes in terms of dehydration. You want to think of renal causes tend to be very rare within surgery, but post-renal is the most common cause within a surgical setting. If they have a catheter in and it's draining a bit, you want to think that they're usually dehydrated. If they have a catheter in and it's not draining at all, the most common cause is a mal-sited or a blocked catheter, and you just want to flush it. So when you want to come to treat it, if it's a pre-renal cause, give them fluids. If it's a post-renal cause, just flush it. Do a bladder scan to confirm, and in most cases that tends to sort it out. Hypertension, very, very common. There's multiple different approaches. Main thing is you can use CHOD as a mnemonic to help you find the causes, if it's cardiogenic, if it's hypervolemia, if it's obstructive, or if it's distributive. In most cases, in an acute setting, you want to give them a fluid challenge to see or to help them get their blood pressure up, and then you want to investigate the causes. If they're losing blood, give them blood. If they have an infection that's causing a distributive shock, treat the infection. If they're overloaded, take some of that fluid off. And if it's neurogenic, refer to neurology. I've never really seen any neurogenic shocks so far. Nausea and vomiting, very common post-op, and in most cases, if you're messing with the abdomen, that can be a very common cause. If they're in pain, it can be caused. In most cases as well, if you're giving opiates, especially morphine, tends to cause people to get quite nauseous. So you can either switch to oxycodone, or you can give them some anti-emetics. Ondansetron tends to work pretty well. Low sodium as well, very, very common thing in surgery. Most common causes SIADH, post-operative, they're in pain. The water's under stress, it doesn't release as much ADH, and as such, you lose a lot of sodium. But one thing you want to keep in mind is what is their baseline, what's their pre-op level. If they come in and they're already hypernatremic, then you don't have to worry about it as much. And when you come to replace it, in most cases, it's just IV replacement. You want to go for normal saline because it has a higher concentration of sodium compared to our blood, and that tends to bring it up. Otherwise, you can go through the pathway. Each hospital has its own. You want to check if they're hypovolemic, but I'm not going to go through that at the moment just because it's quite complex and it's a medical cause, and this is surgery. Let's avoid it. All right, next up, hypertension. Very common. In most cases, if someone's hypertensive and they have a high resp rate, the most common cause is that they're in pain, especially if they've had an operation. Other causes tend to be a PE, or urinary tension. But if someone has a high blood pressure and a low heart rate, then you want to be a bit more concerned, just because it could be something else. And in most cases, because they're hypertensive, just give them some antihypertensives and it sorts it out. If they're in pain, give them analgesia. If they're in retention, put a catheter in, treating the causes. Acute confusional state, very common, especially in the elderly. If they have an infection, they can get quite delirious. With an operation, that's much worse. It's more taxing to the body, so they're very prone to having delirium. And as you can see here, a really good mnemonic is the phrase delirium, where each letter stands for something. I'm not going to go through it in detail, but in most cases, you want to give them analgesia and try to treat the cause. And lastly, DVT. In a surgical patient, it is very important. And that's just because if you don't give these patients any thromboprophylaxis, they're at high risk of forming a clot. In most cases, 20 to 25%, 25 to 50%. And that's just because they're not mobilizing. They're sitting there. They have systematic inflammation or localized inflammation due to the surgery. And if they're sick, if they have like sepsis going on and they're dehydrated, they're all at high risk. This tends to happen at day 5 to 10. Just when all those factors have kicked in and caused a high risk and chance of a blood clot. And as with any DVT, it presents with unilateral erythema, swelling, and pain. And the way you want to approach it is doing the Wells score to help you assess how likely they are to have it. A D-dimer might not be the best option in a surgical patient just because it might be a false positive, and as such, you want to go for a Doppler if you're suspecting DVT. If you're suspecting a PE, just go for a CTPA. And if you have a suspicion that someone has a clot, then you want to treat it with an anticoagulation. But as always, you want to consider the risks and the benefits. If they're high risk of bleeding, then discuss with the hematologist. All right, now we're going to go through the questions. As it's going to be recorded, take this as a moment to pause on the question, read through it, formulate an answer, and then we'll go on to the next question. All right, so that's question 1. I'll leave this on for the next 15 seconds. All right, take this as a moment to pause if you need any more time. Go on to question 3. As well, take this as a moment to pause if you need any more time before we go to question 4. All right, question 4. And lastly, question 5. All right, take this as an opportunity to pause if you need any more time. Thank you. I'll go through the answers soon, but before we do so, please, if you have the time, take this opportunity to scan this barcode, give me some feedback. It's really highly appreciated and will help me in the future when it comes to applying for my core surgical training. Thank you for being with me and listening to this podcast, not podcast, sorry, this recording. And let's get cracking on with the questions. So starting on with question 1, I do realize these are quite dense questions. They're very much similar to the exam questions, especially if you're a final year. They're very information dense. Some of it might not be important. In this case, let's go through it. First thing you want to keep in mind is that this lady had a laparoscopic appendicectomy. She had the procedure. She's pyrexic afterwards. She's type 2 diabetic, which puts her at a risk for poor wound healing. Things you want to keep in mind is that she has worse pain, and things that help you rule out any other differentials is there's no vomiting, there's no nausea, there's no abdominal distension. She has a normal BP, and her kidneys are working fine, and you can say that because she was given a 100 ml and she excreted 800 ml. with 200 ml being insensible loss in most cases. And in physical exam, she's doing well. She's shaking and she's shivering, which shows that there's an element of fever going on. That's some rigors. Surgical site looks intact, but the surrounding skin appears red and infected, which should give you major hints. And what you can see here is there's some bowel sounds present, and on blood, some mild leukocytosis, which all confirm an element of infection with a negative urine dip. So let's go through it step by step. Alcohol withdrawal, highly uncommon. It wouldn't present this way, wouldn't present with a fever, and wouldn't present with a lady this late on. Post-op ileus would be unlikely just because she's not vomiting, she's not distended. A UTI would be unlikely just because the urine dip is negative, and a bowel perf could be a possibility, but the fact that her abdomen isn't distended, she isn't in any pain, would all point against or would be against it. So the most likely cause with a red raw skin infection, with a red raw wound and fever is a wound infection. Going on to question 2, we can see that this patient is day 5. So there's a high chance that there's an issue with wound healing. They've had an operation, and over the past couple of hours, they've developed some abdominal pain and temperature and AF. In this case, AF can develop secondary to infection or secondary to sepsis, which just shows that it's quite severe and systemic. And other investigations below, which is likely to be useful. So in this case, what are we thinking? We're thinking a patient had an operation, they're day 5, most likely to have issues with healing of any tissue, and they're pyrexic. So we should be suspecting a bowel or like an anaesthetic leak. An X-ray would be useful as a first-line investigation, but it wouldn't really tell you much more if there wasn't really any distension. An abdominal ultrasound scan would just show if there's any fluid, but otherwise isn't quite diagnostic. An echocardiogram wouldn't really be useful at the situation. You would never really use an echo to look at AF. Because with an echo, you want to look at structural abnormalities or deformities, and measurements of cardiac enzymes as well wouldn't be really helpful within an AF setting, just because you're not thinking of any tissue loss. In this case, you want to do an abdominal CT scan to further investigate, to further confirm an anastomotic leak, and to find out where it's leaking from so that it can guide you for any further operative procedures. Question 3, things you want to keep in mind is 1, she's quite young, 2, she's had an operation. And things that should scream red flag is she's tachycardic, she has cool peripheries, she's hypotensive, and you can see that there's bruising everywhere. So things that are pointing out is 1, or things that should be going through your brain is 1, she's bleeding because she's young and she has low BP and the signs of bruising, and she's 5 hours post laparoscopy. So that you should be thinking of secondary hemorrhage. In this case, giving IV fluid wouldn't really help just because she's losing blood, so giving fluids isn't really the solution. Booking right chest X-ray isn't really helpful as well. You can use it to help rule out any perforation, but in this case, it's a bleed, limited benefit, maybe something you could think of later on, but not really the situation. Emergency transfer theater is the best solution, or is the most definitive solution, but it's not something you want to do early on right now, and sometimes you can take them to IR. And booking an urgent CT angio might not be the best solution at all in this case, just because, yes, it's going to help you diagnose it, but it's not going to help you manage the situation. And to manage someone who's actively bleeding, you just want to start the active major hemorrhage protocol. Going on to question 4, you have a 54-year-old woman who presents anterior section for cancer. What you can say is he's day 4 post-op, and he's nauseous, he's vomiting, he hasn't opened his bowels, he's distended, and bowel sounds are absent. When someone says bowel sounds are absent with an abdomen distension, you want to think ileus. First line investigation is, as we said, an abdominal X-ray, and what that's going to help you see is dilated bowel loops. A chest X-ray wouldn't really be helpful because you want to rule out perforation. In this case, you want to look at an obstruction. You can't really see it because it doesn't show you the abdomen. Gastrographin can be used to help look into and find and confirm if it is an ileus, and sometimes giving the gastrographin itself can help resolve an ileus, but it's not a first-line investigation. Urgent CT abdo is very helpful, but in most cases you wouldn't really do a CT abdo to diagnose an obstruction unless you have a first abdominal X-ray to confirm it. And flexi-sig, very limited benefit just because
it's limited to the distal end of the colon and the bowel and might not be relevant in this case where it's an issue with the peristalsis. Question 5, very same thing. What you want to look at is he's day 8, so it's in that period where there's issues with wound healing. They have a temperature and they have localized pain with the distended peritonitic abdomen. So that's telling you that there's an issue with a single part that's likely a source of infection. It's localized to one part of the abdomen. So all of this is pointing towards a pelvic collection. Bloods-wise, what you can tell is white cell count is high, showing that there's infection. CRP usually is a really good indicator. If a CRP is greater than 200, it's very likely to be a pelvic collection, or is a high indicator for a pelvic collection. Creatinine just shows that she's dehydrated, and high urea as well in this case very much points to that. It's very limited information. So bowel perforation in this case wouldn't be as relevant because bowel perforation wouldn't present with a localized peritonitis. It would present with just generalized peritonitis and wouldn't present at this point at day 8. Secondary hemorrhage would be unlikely because in this case you can tell that there's an infection going on because she's pyrexic. Wound infection as well, it wouldn't present this way just because the question would tell you that there's a localized infection, and with a wound infection, as with the previous question, in most cases there's mild leukocytosis where the white cells would be around 14, 15, nothing as high as 23, and spontaneous bacterial peritonitis. In this case, because she had an operation, it wouldn't really be spontaneous, so it has to be a pelvic collection.